dear chairperson, dear audience, my topic is about the investigation of pathomechanisms of heart failure and the new methods for its treatment with and without drugs. I'm working at Városmajor Heart and Vascular Center as a resident doctor and a PhD student. My mission is to find more personalized treatment for heart failure patients. I have two ongoing projects at the TMP. The first one is about the predictive value of scar burden assessed by cardiac MRI on sudden cardiac death in patients with cardiac resynchronization therapy with the methodology of systematic review and meta-analysis, and with the same methodology, topic about the effectiveness of non-furosemide drugs with diuretic effects in the management of acute heart failure. So about my first project. We know that it's a great problem that the 5-year mortality rate of heart failure with reduced ejection fraction can reach 50%, out of which 10 to 20% die suddenly. The scar burden is believed to be a major cause of sudden cardiac death, and the cardiac MRI is the most accurate diagnostic tool for assessing scar burden as far as we know. The implantable cardioverter defibrillator is the gold standard therapy for sudden cardiac death events treatment, and choosing the optimal device out of ICD, cardiac resynchronization therapy with defibrillator function or with pacemaker function would save more lives. We miss that there's no clear evidence regarding the guidelines for optimal device choice. Our clinical question was that what is the association between the degree of scar burden assessed by cardiac MRI on sudden cardiac death in CRT patients. That's why our patient population is patients undergoing CRT therapy. We have our prognostic factor as the scar burden assessed by cardiac MRI, and our outcome is sudden cardiac death events. Scar burden assessed by cardiac MRI is based on late gadolinium enhancement method. Our hypothesis is that the higher the scar burden, the more effective is CRT-D in reducing sudden cardiac death events. We think that as for clinical implication, the optimal device choice would decrease the mortality, the morbidity, and lower the costs and the complication rates. Out of almost 10,000 articles, we ended up with 16 eligible articles for our research. Our outcome, as I mentioned, was sudden cardiac death events, and we used the measure of effects of odds ratio in our analysis, where we made a dichotomization based on late gadolinium enhanced positivity for a scar burden positive patient population, a scar burden negative patient population. What we found in this subgroup analysis based on time trend, where the median follow-up time of all the articles were 42 months, we made less than 42 months subgroup and more than 42 months subgroup. We found no difference regarding the two different subgroups altogether, but we find altogether a clinically significant difference, as in the scar burden positive patients, there were much more sudden cardiac death events. As for a univariate risk model, where we used the measure of effects of hazard ratio, we found almost 2 times higher risk of getting sudden cardiac death events in the scar burden positive patient population compared to scar burden negative one. We also look for the multivariate risk model for these articles, where we still find 1.7 times higher risk for the scar burden positive patient population compared to scar burden negative regarding sudden cardiac death events. And we looked for survival analysis, the biggest evidence, and with the analysis which could give us the best estimate, the competing risk model, where we find clinically still relevant result, but mathematically not significant, as we found a 1.5 times higher risk of getting sudden cardiac death events in the scar burden positive patient population compared to scar burden negative. But as you can see, we have a clear outlier data Sliva's article, which is quite interesting because that was the article with the longest follow-up time and the biggest patient population. We had a subgroup analysis, which gives us the best results. We think what we found is that subgroup analysis of CRT-only patient population compared to CRT plus ICD, the mixed cohort. And here we can find that in the CRT-only patient population, as you can see, there wasn't significant difference regarding sudden cardiac death events in the scar burden positive and the scar burden negative group. Although in the mixed cohort where there were primary prophylactic ICD patients as well, there was. Altogether, this is the first meta-analysis focusing on CRT patient population in the topic, with a large number of patients, more than 2,500 patients altogether. But we certainly have our limitation as it's a heterogeneous patient population, and we couldn't find an optimal cutoff value, and we had no results for CRT-P and CRT-D patients. Altogether, we could say that in this high scar burden, it's associated with 2 to 6 times higher sudden cardiac death events. And in the CRT-only patient group, the scar burden was much lower. We would say that we could use as an implication for practice that scar burden assessment helped detecting ICD candidates, and we definitely need a uniform assessment method. Our manuscript was accepted in the clinical research in cardiology. Our second topic is about the effectiveness of non-furosemide drugs with diuretic effects in the management of acute heart failure. We know that acute heart failure has a poor prognosis with a high rehospitalization rate. The treatment is multimodal, but diuretic therapy is a cornerstone. As standard of care, we use loop diuretics, which could lead to activation of the RES system and the sympathetic nervous system. The extensive use of these drugs could lead to diuretic resistance and thus worsening to kidney function, leading to high long-term mortality rate. We was wondering how to maintain the diuretic efficacy with less loop diuretics or to increase the decongestion with additional drugs. Our patient population was patients with acute heart failure. Our intervention was the combined diuretic therapy with loop and non-loop drugs compared to the standard of care of loop diuretics. We looked for the diuretic effects as outcomes like the eGFR change, serum markers, body weight natriuresis, the therapeutic effects like the length of stay, readmission rates, and mortality, and the decongestive effects as well. So finally, we ended up with 33 eligible articles, and now we are at the data extraction phase. So this is the summary of my work here, and I was happy to present my findings on different international conferences. Thank you very much.
Congratulations for this very interesting topic and your research. But did you look a little bit at the etiology of heart failure? Because normally this scar discovered at MRI are associated with coronary artery disease. So it is important also to take account the cause of the heart failure, I think.
Yes, perfect question. We was really dealing with this question from the beginning. After all, as we couldn't make a comparison between non-ischemic etiology and ischemic etiology because of lack of patient-level data, we asked for just to have a hinge in the topic, we made subgroup analysis for only non-ischemic patients because we didn't have only ischemic patient subgroup analysis. What we found in the non-ischemic patient population is that they had around 46% of late gadolinium enhancement positivity, which is quite interesting because even though they are non-ischemic, they still have fairly large amount of scar. And as we know, and you mentioned that the major etiology is normally the ischemic heart disease, the second biggest etiology behind the sudden cardiac death is dilated cardiomyopathy, could be, which is more kind of a diffuse fibrotic tissue in the myocardium. And this diffuse fibrotic tissue could also diagnosed by the MRI as late gadolinium enhanced positivity, and it also gives sudden cardiac death risk for the patients.
So you have to precise in this case that is diffuse scars,
yeah,
not segmental. So there are the scars perhaps related also some myocarditis, I don't know, in their past. Yeah.
Yeah, we try to exclude all the specific cardiomyopathies like amyloidosis, hypertrophic cardiomyopathy, or myocarditis, for example, as a disease causing Lg positivity. These were excluded. So only patients with ischemic and non-ischemic dilated cardiomyopathy.
I have also a question that one of the most important predictors of the success of resynchronization is the left bundle branch block, I mean the width of the left bundle branch block. Was there any relation with the amount of the scar and the left bundle branch block type, or I mean the width of the left bundle branch block, or was it investigated at all?
Yes, this is also a very good question, and we was also thinking about that. I didn't brought the baseline clinical characteristics table, but we checked the QRS width reported in the articles, and we found that in the CRT patients, it was 142 milliseconds as far as I remember, but they didn't report differences in the outcomes.
Okay, thank you. Thank you. And the second question is that if I remember well, maybe you are better in that the MODIT study, the first study which was primary prevention of the arrhythmia-related death, showed that the ICD implantation is the most effective if the ejection fraction is less than 30%. So was there any subgroup analysis, and which would show that if it's beyond 30%, maybe the results are not as effective as we think, or there was no any possibility for that because the limitations of the study?
This is also it's a great question. We checked the mean ejection fraction, which was 27%. It's this patient population, and as regarding, we only had patients with CRT who had ejection fraction lower than 35%, and the ICD patients were only primary prophylactic, so they also had ejection fraction below 35. We didn't really have any data on the variance of the ejection fraction.
It's an important point, should be investigated later, a good point. And the third question is that only the MRI is the useful method for diagnosing scar, or new echocardiographical techniques like the, I don't know what kind of techniques, the strain rate imaging, for example, speckle track strain rate. Is it good for diagnosing scar, or no way for making that? What do you think?
I think echocardiographic measurements like the speckle tracking methods is another very robust tool for this. Imaging techniques like CT is also used. I have read when accessing the different articles that they try to assess the sudden cardiac death with contrast-enhanced CT scan, but altogether the sensitivity and specificity measurements were much better having contrast-enhanced MRI.
MRI, yes, thank you. And final question is that, is there any laboratory marker, siRNA or a classic laboratory chemical marker, which could refer to the fact that, okay, this patient has more scar or less scar? Or do you know something about that?
Well,
I don't know.
Well, then, I think there have been many investigation, experimental in rats regarding this topic in silencing mRNA, but to tell you the honest, I think it's not at the phase that in clinical use it's useful.
Thank you so much. Very nice presentation. My question would be, I saw that you dichotomized your outcome of scar burden. I imagine because you had very heterogeneous outcomes and measurements for it. What were some of the measurements for scar burden in some of your key articles?
At the outcome measurements, basically sudden cardiac death as an outcome was the most interesting outcome. As for outcome measurements, as we had to have a dichotomization based on Lg positivity and negativity, we had these nominal outcomes like yes or no, you know, and that's why we had outcome measures like hazard ratio and odds ratio reported from the different articles. So that was we could use. But of course, we checked deeply the literature, and for example, the extension of the fibrotic tissue in the myocardium can be measured, for example, the percentage, or measured by the mass in milligrams standardized to the weight of the heart. And there were some cutoff values in one or two articles where they found that 9.5 gram of fibrotic tissue, above 9.5 gram of fibrotic tissue, there's a significantly higher chance for sudden cardiac death events, but we didn't have a widespread reporting on these data, so that's why we used these outcome measurements.
Congratulations for your nice presentation. I have actually two questions. I saw the subgroup analysis from the first forest plot. My question would be that is it an arbitrary set follow-up time that you considered to be the cutoff, or there is some rationale behind that, or it is an important follow-up cutoff time? My other question would be that I've seen that there was an outlier almost in every forest plot. What was the reason for that, the hazard ratio were much higher than in the other studies, and also the confidence intervals were very wide for that? So basically, what was the explanation for that?
Yeah, thank you very much for the questions. Regarding your first question, pulled all together the articles, the mean follow-up time were 42 months. That's why we choose for the odds ratio analysis this less than 42 and more than 42 months, because it was the mean value. Regarding your second question, yes, there have been clear outliers. The cause could be the heterogeneity of patient population on one case. The other problem that we was thinking about is that in not every single article they defined sudden cardiac death events the same. I mean, there were some articles where they said that we are measuring sudden cardiac death events, but they didn't going behind the pathomechanisms of sudden cardiac death events, because we know that there have been major arrhythmias like VT and VF, ventricular fibrillation and ventricular tachycardia, which lead to sudden cardiac death events, and the ICD therapy can abort these arrhythmias. But for instance, there could be electromechanical dissociation, for example, which could lead to sudden cardiac death events, and in these cases, the ICD therapy doesn't really affect anything, for example. So we was thinking about that maybe those articles which didn't report this exactly could lead to difference.
I would have two theoretical questions. The first one would be, in the case of the odds ratio, would you expect it to be time dependent at all in this case?
Expect it to be time dependent?
Yes.
We try to have, first we have the measurements of reported in hazard ratios in all articles, but we try to assess the event numbers from the different articles, and we could assess only these articles when we have the proper event numbers and the follow-up time to calculate the odds ratio. This is, I wouldn't say that it's perfect, but that was the only way to have a closer results to time-dependent events.
So then these were calculated from the hazard ratio articles. You counted the events until 42 months or whatever.
We calculated from the incidence of the event numbers.
So yeah.
And the follow-up times.
So I'm just asking because we've just talked in the break about this, and I was thinking that there's no difference between the below and above 42 months, and I was just thinking that why would there be a difference, because we are talking about proportional hazard models. So we say that the hazard in the two groups is proportional throughout the whole time period. So based on that, the odds should also be proportional
yes.
throughout the whole time period. And my other question is regarding this proportionality of the hazard. So would you say that the two groups are scar burden positive and negatives? Would you say that the scar burden positive and negative hazards can be said to be proportional to each other, or is there... So in my head, if I have scar burden, then my hazard will get worse and worse and worse and worse as I more than proportionally compared to the healthy population. So in this case, is there a worsening tendency in the symptoms of the scar burden positives or not?
I think definitely yes, but to have a proper answer to this question, we should have had a more quantitative analysis of the data, I think, and we didn't have data for that to make it.
Yeah, I was just thinking because one of the articles you said that the longest follow-up period article had was a big outlier, and
yes.
maybe this could be the reason that as time goes on, the proportional hazard assumption cannot be held.
Yeah.
So,
yeah, that certainly would be a limitation of the analysis. Thank you.
Just one answer for that. So the scar burden itself, it's really important, but the location of the scar is also an issue. And it was not investigated in this point. Just think it over that if for example, excess stroke comes from the left ventricular outflow tract, that's much more dangerous than it comes from any other place. So it cannot be answered from this point, in my opinion.
Yes, okay, exactly.
Let me just ask that you performed a multivariable model of your data analysis. What were the other clinical parameters you entered into the model, like New York Heart Association stage ejection fraction, NT-proBNP levels, or what else?
So basically we listed all the parameters that we had the multivariate analysis on. It was left bundle bench block, hypertension, diabetes mellitus, ejection fraction, New York Heart Association score, and the etiology where we had the etiology.
Were you able to introduce medical therapy into the model? Because I observed you introduced papers from 2012, 2018, 2022, and medical therapy for heart failure changed a lot. And we know that certain medications, for example, RNAs, reducing the risk of sudden cardiac death, or SGLT2 inhibitors, reducing the risk of sudden cardiac death, but certainly that were introduced into the medical therapy at a different, time points, and it might also influence the results.
Yeah, exactly. It's a very good finding. We try to find the exact numbers, that how was the incidence of the sudden cardiac death events in the different articles, and as in the literature we saw that the incidence is getting lower and lower, exactly because that the RNAs and SGLT inhibitors and in general the medication is getting better and better. So this is something that's definitely behind the scenes. Maybe we could have go for a subgroup analysis for more recent studies and the later and the studies back in the day, but we didn't have that so much articles to have definite results for that. What we also know that, for example, cardiac resynchronization therapy compared to ICD on its own, the CRT also leads to a lower incidence of sudden cardiac death events. That's why it is very interesting to have the defibrillator function on with the CRT or not.
Okay, and another question to the second part of your talk, that's very interesting. And could you just mention a few drugs you are considering in this second phase of your study beyond furosemide?
Yeah, of course. So we try to, we didn't want to select on specific drugs, because initially, of course, SGLT2 inhibitors are hot topic, and there have been meta-analyses on the topic that they are already good in the acute heart failure. So we didn't want to exclude some drugs, so we try to see everything. We've had SGLT2 inhibitors, we had hydrochlorothiazide, thiazide diuretics, acetazolamides, SGLT2 inhibitors, mineralocorticoid receptor antagonists, and we were even thinking to check the data about, for example, positive inotropes like the dobutamine or dopamine, because we have data on that as well.
Also, I think you have to pay attention to the kind of resynchronization, so of the simulation, in a classical way or in the physiological one, because in the last time we discussed a lot about this kind of stimulation. So you have to pay attention at this modality of the resynchronization, because sometimes it's possible to aggravate the risk of sudden death. That is very important.
Yes, like the conduction system pacing methods, it's also a hot topic, left bundle bench area pacing. These are also kind of resynchronization methods. So we could have checked it, but it haven't been developed a long time ago, so we do not have too much data on that.